Welcome to Weekly Neurology Deep Dive. This week, we're diving into periodic EEG patterns.
Fascinating stuff, really.
And a bit complex, too, so this deep dive is purely for education.
No commercial angles here, just a solid overview of the topic.
Exactly, but to really get a good grasp on it, I do recommend exploring the source material, too.
Absolutely.
But today, our main focus is on how this knowledge can be used by neurologists.
Yeah, in their daily clinical practice, we want to make this practical.
So let's set the stage a bit. Imagine you are looking at an EEG from a patient in critical care, and you notice something different about the patterns.
An unusual rhythm, maybe. A repetition that kind of jumps out at you.
Exactly. What you are seeing could be periodic EEG patterns.
And understanding them can be really critical for both diagnosis and treatment.
They can be pretty subtle, though.
They are essentially recurring discharges that you see on the EEG, often taking the form of spikes or sharp waves, and they occur at fairly regular intervals.
So why are these rhythmic blips so important?
Well, they're like a warning sign, a red flag that something might be off.
You mean like a neurological issue?
Yeah, like a brain lesion, an infection, even a metabolic disturbance. It's like a smoke alarm going off in the brain.
You can't just ignore it.
Exactly. Gotta investigate.
So let's walk through some of the most common types that neurologists encounter.
Sure. We can start with PLEDs. Periodic lateralized epileptiform discharges. They're the most common.
And the most studied, I bet.
Yes. And they often show up after things like a stroke.
Signaling localized distress in that brain region.
Right. But you can also see them with tumors or infections, so context matters.
So like a localized distress signal, what happens when those signals are coming from both sides of the brain?
Then you get bipolds. Bilateral, independent, periodic, lateralized epileptiform discharges.
So basically PLEDs on both sides, but independent of each other.
Yeah. And bipolds, they're often linked to really serious conditions like anoxic encephalopathy.
And they generally have a worse prognosis than PLEDs.
Unfortunately, yes.
And what about when these patterns involve the entire brain,
Those are GPEDs, generalized periodic epileptiform discharges.
affecting both sides of the brain at the same time?
Yeah, in a synchronized manner. It's like a widespread electrical storm happening in the brain.
These GPEDs sound pretty serious.
It can be, and actually it can be difficult to distinguish them from non-convulsive status epilepticus. So a thorough assessment is really important.
So we've got these localized signals with PLEDs and bipolds, and then this widespread activity with GPEs. What else is out there?
Well, GPEDs can actually be further subdivided. You've got PSIDs, periodic short interval diffuse discharges. These have a fast rhythm,
What are they associated with?
often metabolic issues, or even Creutzfeldt-Jakob disease.
And are there slower ones too?
Yes, the PLIDs, periodic long interval diffuse discharges, slower rhythm, more specific in terms of what they can indicate.
Like what?
Sometimes they can be a sign of SSPE, subacute sclerosing panencephalitis.
So recognizing the specific rhythm and interval is important.
Definitely. It's all part of figuring out what's going on.
Okay, so we've got the PEDs, the BBLDs, and the different types of GPEDs. Are there any other periodic patterns neurologists should be aware of?
Triphasic waves are another one.
What makes them special?
They have a very distinctive three-phase waveform, and while they are not always epileptiform, they are often tied to metabolic disturbances.
Like?
Liver or kidney failure, for instance. Think of them as a unique electrical signature of metabolic distress.
That's an interesting way to think about it. So we have all these rhythmic patterns and then these triphasic waves.
Well, there's also the SERPIDs, stimulus-induced rhythmic, periodic, or ictal discharges. They're a relatively new category.
New in terms of our understanding of them.
Exactly. And what's interesting about them is that they're triggered by external stimulation.
What kind of stimulation?
Things like a sternal rub or sectioning.
So even minor stimulation can set them off?
It can. We're still learning about the implications of SERPIDs and how best to approach them. It's a very active area of research.
So there's still a lot we don't know, but it sounds like these periodic patterns offer some pretty important insights.
They do. They're pieces of a larger puzzle, and understanding them is crucial for providing good care. We've been talking about these different periodic patterns we see on EEGs.
And how they can provide clues about what's going on neurologically with the patient.
Right. But let's dig into how these patterns actually translate into clinical practice, how we use this knowledge in the real world.
That's what I'm really interested in. How do we apply this to make decisions about our patients?
Well, the first thing to keep in mind is that these patterns are usually not benign. They're often a sign of some acute dysfunction or injury in the brain.
Oh, so we shouldn't just brush them off.
No. And sometimes they can even indicate ongoing seizure activity.
So we need to investigate further, see what's causing them.
Absolutely. And one of the big debates in neurology is whether these periodic patterns are themselves seizures.
That's a tough question, I imagine. What's the thinking on that?
Well, it's complicated. Sometimes they are seizures, sometimes they're not. But even if they're not a seizure in the classic sense, they still need our attention.
So what's the best approach for a neurologist who encounters these patterns?
You have to evaluate the patient carefully. And don't just focus on the EEE findings alone.
Right. Look at the whole picture.
Exactly. Consider their medical history. What symptoms are they having? What do other tests show? Look for any underlying causes that might be contributing to those patterns.
Like a recent stroke.
Exactly. Or signs of an infection, any metabolic abnormalities.
And what if you suspect non-convulsive status epilepticus?
Then a trial of anti-seizure medication might be warranted.
So the medication can be both treatment and a diagnostic tool in a way?
It can, if the patient improves clinically and the EEG normalizes after starting the megs, it supports the idea of non-convulsive status epilepticus.
Okay, that makes sense. Let's say a patient presents with altered mental status, and their EEG shows PLEDs. What would be the next steps?
Well, the first step is to figure out if those PLEDs are truly epileptiform or if they're just reflecting an underlying brain injury. So we look at the shape of the discharges. Are they sharp? Are they spiky? Do they have slow waves after them? All of those factors are important.
So it's not just the pattern itself, but the specific details of it.
Precisely. And again, clinical context is crucial. Does the patient have a history of seizures? Are there any subtle clinical signs that suggest they might be seizing? We have to put all of that information together.
And if you strongly suspect that the PLEDs are seizures, what do you do?
Then you need to act fast and treat aggressively. Non-convulsive seizures can be just as harmful as convulsive seizures, even though they're often silent.
So you might start them on anti-seizure meds.
Right. And then closely monitor their clinical response and reevaluate the EEG to see if those PLEs have revolved.
What if those PLEDs aren't from seizures, though? What if they're just a marker of the underlying brain injury?
Even then, you might still consider a trial of anti-seizure meds, especially if that patient is at high risk for developing seizures later on. It's a risk-benefit analysis.
A balancing act.
Exactly. Every decision involves weighing the potential benefits and risks for that individual patient.
Okay, so let's say you've done all that. Evaluated the patient, looked at the EEG, considered everything, made your treatment decisions. What's next?
Continued monitoring is key. Keep a close eye on the patient's clinical status. Repeat the EEG as needed.
Because those patterns can change, right?
They can. New patterns might appear. Old ones might evolve. Serial EEGs give us a lot of information. They help us adjust our management plan as we go.
It's a very dynamic process.
Very much so. It requires knowledge, skill, and a willingness to adapt as the situation changes.
Sounds like interpreting these patterns is part science and part art.
I think that's a good way to put it. You need a solid understanding of the electrophysiology, but also a sense of the clinical nuances of these cases.
It's challenging, but rewarding too, I imagine. One last thing I want to emphasize. These patterns, they can be associated with a wide range of neurological conditions.
That's why it's so important for neurologists to think broadly. Don't jump to conclusions. Keep a wide differential diagnosis. Consider all the possibilities.
Like a detective piecing together clues to solve a mystery.
I like that analogy. We gather evidence from the EEG, the patient's history, the exam, other tests, and try to create a coherent picture from all of that.
And sometimes that picture isn't clear right away. It takes time and effort to get to the bottom of things.
That's part of what makes neurology so interesting. It's a constant process of learning, discovery, and problem solving.
So we've spent this whole deep dive exploring these really fascinating periodic EEG patterns. It's like they're these electrical whispers telling us what's going on in the brain.
It is. It's like we're learning a new language, the language of the brain's electrical activity.
And the more fluent we become in that language, the better we'll be able to understand and care for our patients.
Absolutely.
So we talked about how PLADs, those localized signals, can often point us to areas of the brain affected by stroke or some other focal lesion.
Right. And then bite bulbs, which are bilateral, they tend to be more serious, associated with things like anoxic encephalopathy.
And then we have the GPEDs, the widespread electrical storms. And those can sometimes look like non-convulsive status epilepticus, which is why it's so important to carefully correlate the EEG with the clinical picture.
Exactly. You can't just look at the EEG in isolation.
And we can't forget about those triphasic waves either.
Right. Those unique signatures of metabolic distress, they often make us think about things like liver or kidney problems.
But I think the real takeaway here is the importance of context.
Couldn't agree more. It's not enough to just recognize a pattern on the EEG. You have to look at the whole patient, their history, their exam, their labs, and see how things change over time.
It really is like putting a puzzle together, isn't it? All these pieces, the EEG, the clinical history, the lab results, they all contribute to the bigger picture.
And sometimes those pieces don't fit together right away. Sometimes you need to gather more information, rethink your initial impressions, adjust your approach as you go.
That's what makes neurology so dynamic. You're always learning and adapting and refining your understanding.
It certainly keeps things interesting.
It does. And the study of these periodic EEG patterns has really changed how we approach brain monitoring, especially in critical care.
It's given us incredible insights into how the brain responds to injury and dysfunction, and even to recovery.
But even with all we've learned, there's still so much we don't know.
Oh, absolutely. We're still trying to figure out exactly how these patterns arise, what their long-term implications are. There's so many questions still to be answered.
But that's what makes this field so exciting, right? There's always more to learn, more to discover, more ways we can improve the care we give our patients.
Exactly.
So to all the neurologists out there, keep those brains engaged and those EEGs running, and never stop exploring the amazing complexity of the brain.
Well said.
That wraps up our deep dive into periodic EEG pattern.
We hope you found it helpful.
Remember, knowledge is power, especially when it comes to understanding the brain.
Until next time, keep those brains engaged, and we'll catch you on our next deep dive.